reviewed the National Cancer Database from 2010 to 2012. That particular time period codes for the type of approach that was undertaken in those surgeries. And we had about 8,000 open cases, as you suggested, 1,000 laparoscopic and 130 robotic. And we first compared the open approaches to the minimally invasive approaches, and we found similar perioperative, oncologic, and survival outcomes. We then performed a sub-analysis on the robotic and laparoscopic cohorts, and again found similar perioperative, oncologic, and survival outcomes. So minimally invasive approaches and laparoscopic approaches were associated with an improved time to initiation of adjuvant chemotherapy. The old school of thought was that patients needed to receive adjuvant chemotherapy within a certain time frame to harness its benefit. But we found that despite this, this did not translate into an impact on survival, so that old school of thought may be flawed. We have improved chemotherapy regimens, which unfortunately this database does not capture which chemotherapy regimens were used. But I think it's highlighting our improvements in treating pancreatic cancer as not just a surgical disease, but a surgical disease that also requires systemic therapy. I think you need to take a look at the facility that you're working in and your experience as a surgeon, and what techniques you're most facile with, and incorporate that into your discussion with the patient. Additionally, I think if you are facile at robotic or laparoscopic approaches, it's important to tell your patients that this is a viable approach, that we have improved or similar perioperative outcomes. We can give you the same cancer surgery, and that we don't really have any evidence to suggest that there's a difference in survival.